I'm excited next to lead into another panel. This is one called Advancements in Maternal Mental Health Screening and Treatment Guidelines and Implementation. One that I've been waiting for, I think it's safe to say, for over a decade. We're going to get to learn about the United States' first set of clinical practice guidelines for maternal mental health developed by the American College of Obstetricians and Gynecology, and also get to juxtapose these clinical practice guidelines, or CPGs, against Australia's guidelines. And then I actually will be sharing more information about the new HEDIS measures for monitoring how often screening is happening here in the United States. Moderating this session is Carla Eckert-Tassanera, one of the Policy Center's esteemed board members. Carla has over 30 years in nonprofit, academic, and for-profit sectors, including serving as the chief operating officer in a prominent U.S. health system and as a country director for international non-government organizations. She currently serves as vice president of clinical operations at Visana Health, a leading telehealth startup in women's healthcare. Welcome, Carla, and welcome to the panel. Carla, I'll go ahead and turn it over to you.
Thanks, Joy, and welcome, everyone. What an amazing morning we've already had. And for those of you not on a US time, maybe it's an afternoon or evening. It's a really exciting panel that we have today, at an accelerated pace that we have for these 30 minutes to look at these incredible guidelines. So I would like to bring on our panelists, Dr. Nicole Hyatt and Dr. Tiffany Moore-Seamus and Joy Burkhardt, our fearless leader and executive director here at the Policy Center. So can they all come to the stage with me? I think they come to the spotlight so that we can do a little round of introductions first and get to know our speakers. And then we're going to do a dive into these guidelines, as Joy was mentioning, and then we're going to have some time for questions. Maybe just a few questions. There's a little time for questions, and then we're going to get some feedback from the audience. So it's very optimistic timeline of 30 minutes, and then there's a break. So I know there's a lot of input. You've had a lot of information coming your way. So Dr. Moore-Seamus, it sounds like, is needing a little technical assistance. So we're going to start with you, Dr. Hyatt, if you could introduce yourself and let us know what's happening in Australia.
Great. Thank you very much, Carla, and thanks for the opportunity to be here today. So I thought I'd talk to you a little bit today about Australia's clinical practice guideline. This is now the third revision of the guideline, which started right back in the early 2000s. And in particular, I'm going to touch on some of the innovative approaches that COPE as the peak body of perinatal mental health in Australia. So that stands for Centre of Perinatal Excellence. Some of the innovative approaches that we've established to really support and implement guideline implementation, but also measuring that impact over time. So if you could please just go to the first slide. Great, so this is the most recent 2023 guideline. So generally, Australia updates their guideline every 3 years. As part of that process, we bring together representatives from all of the peak bodies involved in the delivery of antenatal or postnatal care or mental health care. So College of Obstetricians, midwives, maternal and child health nurses, as well as psychologists, psychiatrists, etc. So it's a very multidisciplinary panel representing the peak bodies. Importantly, the guidelines are then at the end approved by the National Health and Medical Research Council. And really, as I mentioned at the beginning, our focus has really been then on, once we've developed the guidelines, how do we support their implementation through innovation? The latest guideline has 103 recommendations and good practice point. And that is informed by using the GRADE method, which is a guideline approach to measuring the evidence. Next slide, please. So I've just broken down the key areas of the guidelines into three major areas. The first area really highlights the importance of the guideline in terms of education for health professionals, education around parent-centered communication, training and the importance of assessment and the use of screening and psychosocial assessment, and the exact tools that we use I'll talk about in a moment, but really providing education and training around how to screen, how to interpret screening results, and what to do next after screening. Training around the assessment and management of those at risk of suicide, how to conduct a risk assessment, and what is the process around referral and management of and safety planning, and also having knowledge around referral pathways and having those in place. And again, we have developed an approach to really support that referral pathways through following screening. Next slide, please. The next area just to touch on is the psychosocial screening and assessment. So the guidelines recommend universal screening of all expectant and new mothers, both early and later in the postnatal and antenatal periods. So currently in Australia, in the public sector, we're getting very good with universal screening in the public system, particularly antenatally and postnatally. But currently, often it's only done once early in the antenatal or postnatal period, and not in the later trimesters or in the from 6 months onwards in the postnatal period. And this is important when we know that a lot of the time the prevalence of these or the incidence of these conditions doesn't always occur early in the ante and postnatal period. So that's an area we're really going to be focusing on, is how do we increase that second screening opportunity in postnatally and antenatally. The guidelines is very clear about the use of the recommended screening tools. Here we're recommending assessment of 2 factors. First of all is the psychosocial risk assessment, and we have the validated antenatal risk questionnaire, which can be used antenatally and postnatally. So this questionnaire looks at known risk factors and generates an overall score, which assesses that overall level of risk. Also then that's looking at the risk profile and only needs to be done once. This is accompanied by the Edinburgh scale. So this still remains the recommended screening tool and currently translated, and different adaptations have also been done for our Aboriginal and Torres Strait Islander population groups. We use the different recommended cutoffs of the EPDS when screening in non-English speaking languages, and advice around that, and also when working with refugee populations. We also have recommended screening tools around family violence, and they vary a little bit from one state in Australia to the next, but certainly recommendations around universal screening for family violence when the woman is alone on her own and the opportunity exists to do that screening. The new guidelines, one new area that we included this time, which wasn't in the previous one, is the recommendation around screening non-birthing partners. So whilst that's a recommendation, it's got a long way to go in terms of policy and practicality when women are still the patient. But given that we know that women who are struggling, their partners are at risk as well, that's an area of focus going forward about how do we do that better. I've mentioned about the cutoff early scores for different speaking languages and also Aboriginal tools. So I'll move to the next slide, please. The guidelines are really extensive in their coverage of the different disorders. So we cover both the high prevalence and low prevalence disorders, and what are the treatment recommendations for each of these different disorders. So for the high prevalence disorders like anxiety and depression, we look at these different types of therapies and what role they play and when they should be considered as part of a treatment program. For severe mental illness, we therefore cover schizophrenia, postpartum psychosis, and bipolar disorder, as well as borderline personality disorder. And a new area of the guideline this time was the inclusion of treatment around psychological birth trauma, which is getting a big spotlight and profile here in Australia at the moment. Next slide, please. So as I mentioned, our focus at COPE, in addition to developing the guidelines for the Commonwealth Government or the federal government here, is around how do we support their implementation through innovation and technology. So the first area is through our online self-paced online training programs. We have training programs for frontline professionals, really focusing on understanding perinatal mental health, when and how to screen and what to do next, and just understanding the basics of different types of effective treatments. We also then have dedicated mental health training programs for health professionals who are already mental health professionals but don't have that perinatal expertise. So the frontline training is free and funded by the government, and the other training is a paid training course. To support psychoeducation for all expectant and new parents, which is a guideline recommendation, we've developed an app called the Ready to Cope app, which is available in Google Play and the Apple Store. So again, this is free for all parents and fully funded by the Australian government. And the app works that a person will put in their due date or when their baby was born, and each week receive psychosocial information that's really relevant to that time in their pregnancy or postnatal period. So it gives that opportunity to showcase the different challenges that they might experience, educate about perinatal mental health problems, how to identify it in themselves or others, and where to go for help. The third big area for us is the development of a digital screening platform called iCope. So this is currently funded by the Commonwealth Government and being rolled out right across Australia, across all states and territories. So this puts those recommended screening tools into a mobile platform. This means the woman can be sent the screen prior to on the day of her appointment, or do the screening in the waiting room of the appointment. And that offers her privacy to be able to do that on her own phone, as opposed to being asked to complete a questionnaire. The system also generates instant clinical reports for the clinician and a patient report in their own language. So this is currently available in 25 languages. And then that directs them to referral pathways. So just on the bottom of the screen there on the right, you can see a sample of the clinical report and the patient feedback that they can nominate to receive by SMS or email. The fourth area is referral pathways. So here we've developed an online perinatal mental health directory of services. So here we review clinical services and support services and integrate these referral pathways with screening scores after the screen has been undertaken. But of course, they're available at any time via the COPE website as well. So that's it for me.
I think we'll have to move through my slides next. So we're going to pop the slides back up, and I'm going to be talking about the new HEDIS maternal mental health screening measures, which I am just thrilled to present to you. These have been years in the making, and something that the Policy Center has been advocating for development of for quite some time. So we're going to fast forward through Tiffany, Dr. Moore-Seamus's slides here, and come back to those. We will start with the HEDIS slide. And let me tell you just a little bit about HEDIS. The maternal, okay, very good. I wanted to start by sharing a little bit more about our focus at the Policy Center on what we call 3As, and how appropriate screening to detect these disorders is one of these 3As. You can see here appropriate screening and of course treatment, but starting with screening, access to providers and programs. We need to have referral pathways and treatments that are evidence-based, and ample insurance coverage. That means covering all of these services, including screening for patients, but also reimbursing providers what it takes to do this work well. So we'll move on to the next slide. A little bit about some of our work around screening. I wanted to share that there's a universal screening for maternal mental health disorders brief that we invite you to check out. You can find it on our website and also in the document section of our session today in the Whova app. It highlights the range of disorders, the screening tools that are evidence-based, the opportunities for screening timeframes, which align with the recommendations you'll hear from Tiffany Seamus Moore here about in just a moment. And the next slide, please. So I wanted to share just a little bit about something called the Alliance for Innovation on Maternal Health. In addition to the clinical practice guidelines that Dr. Morsemus will be sharing with us here in just a moment. I believe many of you in our space have heard about the Alliance for Innovation on Maternal Health. This is a body that works on creating evidence-based solutions to prevent maternal mortality and morbidity, preventable maternal deaths or errors, mistakes, challenges in maternal health care. This work is championed by and funded by the federal government, the Health Resource and Services Administration, and ACOG, the American College of Obstetricians and Gynecology, is a contractor for this important work. So I wanted to share a little bit about the recommendations for screening under the AIM, what we call bundle. If you hear that word bundle, we really mean a set of recommendations, also tools for implementation, and actually measures, which we'll talk about HEDIS here in just a moment. So quickly, the Alliance for Innovation on Maternal Health recommends that individuals receive from their primary provider or obstetrician in this case an assessment of their risk for maternal mental health, so their own mental health history and family mental health history, and then do that intake and that review again as needed throughout the perinatal period. And then screening, that's the questionnaire that's provided, usually 9 or 10 questions in the most utilized depression screeners in perinatal mental health. Screen for depression and anxiety in the initial prenatal visit, later in pregnancy, as we heard Nicole talk about, more than once in pregnancy, and also at postpartum visits, and ideally including pediatric well-child visits as well. Bipolar disorder should also be assessed for to rule it out before initiating pharma treatment for depression and anxiety. And that's in order to prevent, of course, know if we have bipolar disorder that needs to be treated, but also prevent postpartum psychosis, potentially. Structural and social drivers for health should also be screened for under the AIM recommendation that may impact clinical recommendations and ability to receive treatment. Next slide. So though we see that the recommendations through AIM and of course the clinical practice guidelines are anchored in the obstetric setting, so the OBGYN, midwife, or family practice provider who delivers babies or provides maternity care, really important that mental health be anchored in this setting. Mom's doctor are the obstetric providers, and we need to start early in pregnancy to detect these disorders early on, prevent preterm birth, and the like. We also want to acknowledge that it's important to think about a no wrong door approach. So if women go to a support group and it's recognized that there may be some struggles, that a CHW, for example, a community health worker, as we heard on our last panel, may also be in a position to screen, for example, or perhaps a behavioral health provider directly if the mother goes directly to behavioral health care. Next slide. So now a little bit about HEDIS. What is this word? What is an AIM bundle? What is HEDIS? What are all these acronyms? HEDIS stands for the Healthcare Effectiveness Data and Information Set, and it monitors how often services are delivered in the U.S. healthcare system as reported by health insurers and health plans. So we are so excited to share that with funding through a couple of our sponsor organizations, the California Healthcare Foundation, who we heard from earlier, and also the Zoma Foundation, we were able to create a measure through the National Committee for Quality Assurance to detect how often depression screening is happening both in pregnancy and in the postpartum period. I want to share just a little bit about the fact that we're advocating for some additional change, including the inclusion of anxiety screening in maternal mental health care. But this first measure was developed and focused on depression screening. So a baby step or a small step for now, which we're quite excited about. And so these measures called PNDE and PDSE, and the E stands for electronic. I'm not going to go into details here, but if anyone's interested in learning more about electronic measures, we're happy to share more, and you can find more information on our website. So these measures look at the percentage of deliveries in which members or patients received screening for clinical depression using a standardized evidence-based screening tool, both in the postpartum period and in pregnancy. And then follow-up on a positive screen is also a required measure. So the percentage of positive screens which received some sort of follow-up, outreach or intervention within 30 days of that positive screen. So next slide shows the preliminary results. So we'll move on to that slide. As reported by the National Committee for Quality Assurance, the measure developers, in 2022, some of you may have been on that webinar with us. These were results from plans that participated in the early reporting in 2021. And you can see that less than 20% of patients were screened according to the HEDIS measures, and that Medicaid screening happened slightly more often at 16% in pregnancy and 17% in the postpartum period than commercial or private insurers, much lower at 9% in pregnancy and 11% in the postpartum. This is often, these results often surprise people, but when you think about it, Medicaid is some sort of system of health delivery and accountability for this population, and commercial and private insurers really aren't accountable in the same way to the government or to women. There's not as much infrastructure in place, so it's not so surprising to us and important to call out that difference. And the next slide, we share some interesting results in our next report that will be released in just a couple of weeks. We wanted to share that it will focus on the latest data set and also the states that are performing the best. And you can see here that Pennsylvania is leading the pack. Tomorrow we'll get to hear from the Medicaid director in Pennsylvania, the medical director, about why Pennsylvania is leading the pack and their focus on prenatal care for women in particular, including maternal depression screening. New Mexico is second, and then on down the line. Stay tuned again for our upcoming report that details what we suspect is driving these improvements, and we're really excited to share what we're learning in that report. And that's it from me. I'm hoping that we have Dr. Morsimas on the line. Tiffany, are you with us?
Thank you, Joy.
Very good.
Are you able to hear me?
We can.
Yes.
Thank you, Tiffany.
Okay, I'm so sorry. Let's proceed. If we could start with my second slide, that would be wonderful. So in spring of last year, 2023, ACOG, the American College of Obstetricians and Gynecologists, put forward 2 brand new clinical practice guidelines as it relates to perinatal mental health conditions. Next slide. In each of those clinical practice guidelines, there are a number of different topics. The first practice guideline is focused on screening and diagnosis, and the second is focused on treatment and management. And as you can imagine, the topics within each of those are aligned. And then next slide. Each of the clinical practice guidelines within those topics makes a number of very specific recommendations and support those recommendations with both the strength of the recommendation and the strength of the evidence. And then you can see the little blue box that says GP. In some cases, there are what's called good practice points, which is either the evidence is so robust and longstanding or it's common sense and this should just move forward. Next slide. In addition to each of those individual recommendations are supported robustly with the evidence, the literature base that supported those recommendations to get at the why, not just the what is recommended, but the why it's recommended. Next. The first clinical practice guideline focused on screening and diagnostic approaches of mental health conditions has 3 major topics. And it's the evidence base in screening and diagnostic approaches to the first topic is perinatal depression anxiety disorders. The second is bipolar disorder. And the third is postpartum psychosis and suicidality. Next slide. For depression and anxiety specifically, these are detailed slides. I wanted to make them available to people. I will give the high-level overview in the interest of time. So regarding depression and anxiety, very clear and strong recommendations around screening for depression and anxiety multiple times in pregnancy and in the postpartum period. And then beyond the perinatal period, also screening at other times like well woman visits, et cetera, and using validated instruments. And then, of course, it's not enough to screen, but really doing the screening in the context of systems that allow you to address the full mental health care pathway of diagnosis, effective treatment, appropriate monitoring, and follow-up. Next slide. With regards to bipolar disorder, very, very clear, strong recommendations around screening for bipolar disorder before initiating pharmacotherapy at a minimum, and a recommended suggestion to do so really for every perinatal individual, knowing that approximately 1 in 5 perinatal individuals who screen positive for depression may actually have bipolar disorder. And then because, bipolar disorder is a severe mental illness and not necessarily within the training and scope of OB/GYNs, but certainly within the purview of the patients that we care for and directly related to perinatal mental health, maternal mortality, suicidality, psychosis, mania, et cetera. A nod to the perinatal psychiatry access programs is a way across the nation to increase the capacity of clinicians to address mental health conditions and to be there as a support as clinicians are addressing mental health. Next slide. With regards to postpartum psychosis and perinatal suicidality, of course, it's not enough to screen, again, for depression, but look specifically at the questions that address self-harm and when self-harm is endorsed, even at the lowest level, to make sure that you pursue questions appropriately, do an immediate assessment, and take a risk-based approach to management. And then stating the obvious around postpartum psychosis being a medical emergency and treating that the same as we would postpartum hemorrhage, hypertensive crisis. It should put people into immediate action. In the second clinical practice guideline focused on treatment and management of perinatal mental health conditions, there are 5 topics. The first is general approach to psychopharmacotherapy, and then individual topics around specific recommendations for pharmacologic intervention for depressive disorders, anxiety disorders, bipolar disorder, and postpartum psychosis. Next slide. With regards to sort of the general approach to psychopharmacotherapy, stating some really important things, which is pregnancy, lactation itself should never be a reason for withholding and discontinuing medications. And then all obstetric care clinicians should be able to counsel regarding the benefits and risks of psychopharmacotherapy. And in the details of the documents, we really talk about a risk-risk conversation because we know there's risk of untreated and undertreated disease. Also recommendations, strong recommendations around obstetric care clinicians initiating pharmacotherapy, referring patients, or ideally both, and really using those validated screening tools once a diagnosis is made and treatment is initiated to provide symptom-based monitoring and titration of medication. Again, it's not enough to initiate therapy, but really are you doing it in a way that is effective in achieving the ultimate goal of symptom remission and improved outcomes for the perinatal individual. And of course, another nod to the access programs as a way to help our obstetric care clinicians do this. The current generation of obstetric care clinicians are receiving more training this than in those in generations past. However, there are generations of obstetric care clinicians that did not, in fact, receive this as part of our training. So really trying to help identify supports and resources to make sure this happens. And then I won't get into the details of the individual recommendations for pharmacotherapy for depression, anxiety, and bipolar disorder, except to point out that they are there and they are meant as guidance along with interventions for postpartum psychosis. And then these guidelines came out in June of last year. And then as many of us know, in August of last year, the FDA approved zuranolone as an oral treatment specifically for postpartum depression. And so following the publication of those guidelines, we then put forward a practice advisory specifically around zuranolone to again help educate and make the obstetric care clinicians aware of all of these potential treatments and resources. And then the final slide, as I've referred to perinatal psychiatry access programs a couple times throughout the clinical practice guidelines and in this brief presentation, just a current map of what states currently have access programs in green. some that are emerging soon to have open lines in blue. And then to make sure everybody is aware, of course, of the PSI National Hotline and the Veterans Affairs National Hotline. So really, everybody, every clinician caring for pregnant, postpartum, and lactating individuals having perinatal mental health conditions has access to support in helping them treat this. So thank you. That's the end of this presentation. My apologies for the technical difficulty.
Okay, well, we know that providers, policymakers, philanthropists, and payers are in our audience. And so with these guidelines and with the very innovative implementation work that we heard that is being done in Australia, and the measurement that is happening with HEDIS, and the efforts that is happening with ACOG, that we're hoping that you are also hooking in and thinking about how that will impact your implementation and thoughtful leadership on these issues, as I know Joy will continue to lead us and drive us to make change. So I just want to thank you for your leadership on this topic. And I know there will be time for questions as we move through the forum. So thank you very much. We are out of time, so I'll hand it back to you, Joy.
Great. Thank you, Carla. Thank you, Nicole, and Dr. Morsemus as well. And well said, closing words, Carla.